Hi, this is Dr. Tom Insel, and I'm going to serve as your moderator for today's conversation, which is about how a behavioral health tech startup can collaborate with a health plan to be able to provide the very best care for people who are covered by the plan. Delighted to have two experts on this who have been working together to do something, I think, rather unique, and I hope will be informative. Let's start with Carl Alexandrov, who is the Vice President of Behavioral Health Operations at CDPHP. And Carl, maybe you can explain what that acronym means and what your role is there.
Good afternoon. I am the Vice President of Operations for Behavioral Health at CDPHP Capital District Physicians Health Plan. It is a not-for-profit MCO in upstate New York.
Thanks. And we're also joined by Larry Ozawara, who is a psychiatrist and the Senior Medical Director for Verily Health.
Hi, Tom, and good afternoon. As Tom said, I'm Larry Ozawara. I'm the Senior Medical Director at Verily Health, which is a telehealth company focused on treatment of mental health conditions.
Well, it's great to have both of you. I think for many of the people who attend this conference, when they think about digital mental health, when they think about healthcare startups in the mental health space, they're thinking either direct to consumer, or maybe working with a payer, or maybe they're going the employer route. You don't see a lot of companies actually collaborating with providers in the way that Verily has done. And I'm just really curious. I think it'll be helpful for people listening in to understand, how did that happen? What was the way in which CDPH and Verily got together? And maybe we can hear it from both sides, but Carl, could you start off and give us a little bit of the background here?
So we wanted to improve outcomes for our members regarding engagement, particularly our Medicaid members and members living with severe persistent mental illness. We saw an opportunity to improve engagement for our case managers. And so we met with Verily, and it was their case management platform, the SaaS, the solutions, the analytics, the capabilities to utilize video and chat and texting to engage our members. And so we executed an agreement to use the case management platform. It was successful. We saw greater engagement with our members who were hard to engage. We were able to download the app before members left the hospital. And so we saw an improvement in our engagement. Due to COVID and gaps in care, we executed an agreement to utilize their telemedicine services. That's the prescribers and therapists. So that was to close a gap in care. But it started with engagement.
So you actually went from software, sort of using that as a linkage, to then going to using Verily for care itself, for yes. providers during yes. COVID. Larry, from the Verily perspective, from the company perspective, usually this is a really big lift. I mean, how did it work from your side? And did you suddenly come up with a bank of providers who could support CDPHP, or was that a pretty tall climb?
Yeah, that's a great question. To be honest, the relationship started before my time. And so when I joined Verily last year, what I noticed was that we had these meetings with CDPHP. And to be quite frank, I didn't know what CDPHP was. And when I found out that they were a health plan, it's like, oh, that's a pretty novel idea to be partnering that closely with a plan. One of the things that we've done from the very beginning is to try to figure out what our partners need and want, and to try to fulfill that as quickly and as effectively as possible. So when a plan comes to us and they say, we have X number of members, we need your help providing services, we, on the other end, recruit as quickly as we can the providers that are necessary to fulfill those requests. And that's partly how that relationship got started. And since then, I've seen an evolution and strengthening of a partnership. And as Carl said, we started with shared goals, and we've been working since then to increase access to care to as many people as we can.
Prior to our agreement with Verily and our partnership, brick and mortar sometimes had a 2-month wait list to see a provider. And when members are being discharged from the hospitals, it's imperative that they have an appointment at least within 7 days to meet the HEDIS. But first of all, it's best care, but also to meet the HEDIS metrics. And when we partnered with Valera, we're able to get members an appointment within 48 hours for therapy and within usually 5 days for a prescriber. So it's really resolved the gap in care for us.
So I got to ask, because this is a very sensitive issue for HEDIS. When you look nationally at the HEDIS performance on that follow-up 7, we're talking about the national average is about 50 to 54%, depending on whether you're in public or private insurance markets. I'm curious how you've done. I mean, what does it look like with CDPHP and Valera together? Where are you?
You want to answer that first, Carl?
Well, I'm very proud to say that we've introduced Valera to all of our hospitals, the inpatient hospitals, and they have a very seamless referral process for discharge from the hospital or the ER. It's very quick, and we've seen an improvement. It's about an 80% success for our members that are discharged.
So that means 80% of them are seen within 7 days?
They have to agree, right? So we're offering it 100%.
Okay.
But yes, the members are those 7 days.
So that's a massive improvement over the national performance.
And that's the 7-day follow-up post-hospitalization. We're still partnering with Valera to improve the follow-up from the ER. I don't have the exact percentage, but we have some work ahead of us for the ER. When a member goes to the ER with a mental health or a substance use disorder, it's been challenging to get appointments.
Got it. Larry, take us through the actual service. So who's doing the care? And are they full-time, part-time? How do they work for you? What's that look like?
That's a great question. So I actually helped launch the FUH-FUM program, which is the one that Carl is describing.
That's the follow-up hospital, follow-up. What's FUM, follow-up?
For medical, for emergency room visits.
Got it. Okay.
And so what we have is we have a team of providers. They're licensed providers, whether it's a therapist or a prescriber. We get notifications directly from the hospital when somebody with CDPHP insurance is being discharged. We have a process where we can schedule them very quickly, usually within 24 or 48 hours, to get seen by one of our providers. We do safety assessments, we do clinical assessments, and we make sure that they get connected to long-term treatment with Valera so that they can continue the progress that they've made in the hospital. We also manage their care for the first 30 days out so that they get frequent touch points. And the idea there is to make sure that they're very well taken care of in that very vulnerable time immediately following their discharge.
And we started with adults, but we moved to children. So our inpatient facilities that treat children, child and adolescents, we now have the same process where the hospital can seamlessly make a referral to Valera for follow-up.
Got it. But now what I'm still not clear about is who's actually doing the care. Or you said that there's a licensed provider who goes to the hospital prior to discharge. They make an arrangement to continue the care, and they set up a meeting. Is it remote care? Is it digital, or are you brick and mortar based, or what is Valera actually providing here?
It's providing digital care. And so it depends on what that member needs. If they need a therapist, we connect them to one of our therapists for long-term treatment. If they need medication management, which they often do, we'll connect them to one of our prescribers, whether it's an adult provider or a child psychiatrist, for example. And our Valera providers are providing the care that they need after the hospital stay.
Got it. And so they have this sort of continuous relationship through the app that allows them to connect with. It's interesting because Valera really started as a software company, built out that content management part of this, and then brought in the actual the high touch as well as the high tech to provide the continuity of care. So a couple of questions that raises. One is, does it scale? I mean, because what you're doing is pretty intensive. You start with a kind of a one-to-one connection. What's it look like in terms of how do you scale services? Does the digital allow you to be able to improve the efficiency of care and to lower the costs, or what does that look like?
That's a great question. And to be quite frank, it's been sort of a learning curve. So at first, when we had fewer providers and a smaller patient population, what we saw was that the providers were doing the bulk of the work, whether it's rescheduling appointments or getting a prior authorization for medication refill, or getting consents or assessments done. What we've done over the last several months is worked very closely with our product team to kind of bridge product with clinical and utilize our technology to provide some of the ancillary services that the providers would otherwise do. So for example, if somebody needs to do a rating scale for depression, they can actually do that on the app. The provider doesn't have to sit in the office, virtually speaking, with them to have that done. If they need a release of information or a prior authorization, the medical assistants actually can help the providers out. So we've turned Valera very much into a virtual clinic, if you will, where we have ample support to help our providers have more face-to-face time with the patients and to really stay engaged themselves in the treatment.
So, I'm listening to this and I'm thinking what is maybe most remarkable is that you've been able to pull this off at all, that with all of the innovation, all the digital revolution that we've seen, a lot of which is talked about in this conference, you don't see a lot of focus on people with serious mental illness who are being discharged either from ER or from hospital. And for whatever reason, they have been largely neglected for entrepreneurs and for innovative solutions. When I've talked to people about that, they often say, well, it's because it's just really hard to get paid. Getting this done and finding the right business model, and when you're working with Medicaid or you're working with the population that has some of the highest needs and some of the highest costs, is really difficult for entrepreneurs. So I'm curious how this has worked for this partnership. What's the business model for Valera? Is it a fee for service? Is it done? Are you going at risk and doing this as a sort of capitated prospective payment model, or what's worked out best, or what have you learned around that?
One thing that I've learned for sure is that delivering high quality care is not incompatible with earning a living, right? And so we are able to create innovative solutions that helps us deliver care to the underserved populations and still, keep a roof over our heads, so to speak. One of the things that we did at first was we started with more of a fee for service model, but we've kind of branched out into more value-based models. Part of the reason behind that is if you think about what health plans are looking at and interested in, they're wanting to serve patients, obviously, but they're also wanting to reduce costs. And if you develop programs that reduce costs to the health plans, then you can sort of share in that the cost savings that the health plans receive. So that lends itself to more about value-based contracting and that sort of thing.
So, Carl, I want to sort of turn that over to you as well. I love your thoughts about this evolution that you've already been through, where you've gone from, all right, first this was software, and then we brought in the care, and that was more like a fee-for-service model. Is there the potential to go at risk to do this in a value-based approach where Valera is given funding and they could provide whatever range of services are necessary to keep patients out of the hospital, out of the emergency room, and to get better outcomes?
So Our first payment arrangement for the case management platform was a per member per month for our members in the platform that our case managers were using to engage the members, to send information campaigns. The next payment model was for the telemedicine services, which was a fee for service, and we initiated a value-based around primarily HEDIS, right? So Valera assists us in improving our HEDIS. So every member that's discharged and referred to Valera, our analytics can run a report and we can determine the success of 7-day follow-up. And at the end of the year, they have the ability to get bonus. So it's value-based around quality. It's also access to care, making sure that our members get treatment. And we're going to expand that. We're actually sent out an RFP, and it's going to be more risk. And that's in the works right now.
And what do you see as the big barriers to doing that? Like, because I think for a lot of entrepreneurs, if they know that there's the opportunity to go at risk and to prove out a thesis that they can give better care with better results at a lower price point, they jump into this. But in most places where it's still kind of fee for service, it's a little hard, a little daunting to take on people who have huge in numbers of social needs. They have enormous amount of disability. It's more feasible if you can go at risk. What's the barrier to doing that? What keeps CDPHP from just saying, okay, good, let's open this up. Anybody who can do this and provide whole person care at a lower price point, go at it?
We're actually storming and norming right now. That's where CDPHP is. Okay. We're actually, with our analytics and our chief financial officer, we are looking at a value-based model based on risk. And particularly for our telemedicine partners, and this is just high level, part of it is a capitated rate based on risk, right? So SPMI would be one rate. Then there would be high risk, which would be a lower rate. And then the other cohort is everyone else. Then there would be quality metrics included. So the QAR in New York State Medicaid, we have specific measures around Medicaid, and two that are really important, and we've talked about them previously, is the ER follow-up and the 7-day follow-up. Some of the other measures might be screening for members who are diagnosed with diabetes and schizophrenia, making sure that their lab work is done. So we're looking at which of the quality metrics, HEDIS, would be part of the value-based. So that's in the storming and norming. That's what we're doing right now, but that's the plan, is to launch that.
Great. I think this is going to be of real interest to a lot of people who are thinking about what's the business model. So I got to ask you, because it's kind of connected to all this, across the US, we're going into this 988 phase. So July 16th, many communities are going to be moving into a new crisis number required. It's required on a national level. A lot of what you do at CDPHP probably gets driven by the crisis care that people have coming to the emergency room, being acutely hospitalized. Do you have thoughts about how to kind of get in front of that? Is there something that either Valera or CDPHP could do together that would improve outcomes from crisis services? Or is that not part of the roadmap?
I can say, from our end, one of the things that's helpful is for, even if it's a crisis worker who's on the phone with a patient, to know that things like Valera and CDPHP exist, right? And so from our perspective, we're branching out to multiple states. We're going to see a rise in ER visits as a result of the crisis calls that come in. We want to be able to provide care for those members who are needing help more quickly than the average person.
And in the RFP that we're developing, we are requesting crisis management plan. Mm-hmm. So is it, okay, we're expecting 24/7 crisis management linkages to our ERs with referral processes. So that's one of the strategies in the upcoming RFP.
Got it. Okay, a couple more things I want to make sure we explain. One is who gets covered in the partnership that you have. I think you mentioned that there's a range of severities, but I thought if I heard you right, Carl, you said that you've extended this to children as well. So what does that look like, and what's involved with now moving into a pediatric population, at least from the Valera side? How does that change the calculus?
So COVID, again, the brick and mortar providers, particularly pediatrics, pediatricians are overwhelmed. We've had several inpatient psych units for adolescents close in our area. And so we met with Valera and strategized, and under Larry's leadership, we successfully launched the Child and Adolescent Program. And it initially was just referrals. So Valera sits on our website, so members can self-refer to Valera. We also have a call center where if a member calls seeking services, we will refer to Valera. We have now developed a partnership where Valera can allow a hospital to make a 7-day follow-up appointment for children, and they reach a clinician within 7 days. So our partnership is very strong in working with Larry and the team to really meet the needs of our community, our catchment area.
And on our side, I think the two things that come up.
I gotta ask. They're not a child psychiatrist, so go ahead.
Yeah, so we're seeing a shortage of child psychiatrists across the country, and it does create some challenges. When we start to get more referrals from the hospitals and ERs, we're obviously going to get an influx of kids coming into our services. One of the things that I think we've done very well about is involving parents, because parents need to know what's going on with their kids. They want to know what's going on with their kids. They want to know how they can help their kids succeed. And we've also, leveraged our relationships with various institutions in New York in particular to recruit child psychiatrists to deliver high quality care.
Last question for me is, if others are thinking about creating this kind of a partnership between tech startup and a health plan, what are the lessons from both of you? I mean, what have you learned here that you think are important for people to know about as they get into those kinds of relationships? Larry, I'll let you go first since you're doing this from the tech side.
Sure. One thing I think is important to do, I'd say the first thing is to do a needs assessment. Figure out what people want, who your audience is, whether it's a health plan or a patient population. Get a sense of what the gaps are, and then start small, form relationships, and then build from there like we did with CDPHP. The one thing, and probably the biggest struggle for me, is just to be flexible, right? So you never know where things will take you. We started one way, we've seen it evolve over time to a different way. We've seen that evolution has been very, very successful. And I think we have to sort of step back and realize that, what we envision is going to happen 12 months from now can be very different from what actually happens in a year.
Yeah, that's what I'm hearing as well. It's just remarkable how this started really as a SaaS partnership, became a care partnership, and now is moving into a value-based care partnership, which is remarkable. Mm-hmm. Carl, what's the message for people listening in on creating these kinds of partnerships with a startup from the plan perspective? What do you think is most important for people to know?
Being clear on the plan's strategies and being open to discussions, right? So with Valera, we started with weekly meetings and we sort of built together. And so I think it needs to be the right fit. It should be a credible startup and a commitment to the work. It's not something that you just sign up, execute agreement. It takes a lot of work to assess the needs and to develop a cohesive approach. So
one of the things I'm hearing from both of you is that this took time, but there had to be a sense of trust between the two sides, and it sounds like you've definitely hit that over time. Mm-hmm. But I guess for people who are wanting to replicate this with other plans, it does take the relationships, and it does take creating that kind of trust. Thanks so much to both of you for joining in this conversation. I just think it's a really great example that what you've created here for the patients who probably have the highest needs and some of the highest costs within the system, to show that you can provide high quality care and do it through this kind of an innovative partnership. So congrats to you both, and thanks for joining us today for this conversation.
Thank you.
Thank you, Tom.